We're now going to stay in Norfolk for a moment because I'm delighted to introduce you to Lee Watson, consultant in public health within Norfolk County Council. Lee is the public health lead for Healthy Ageing, the Marmot Place programme in Kingsland and West Norfolk, focused on tackling health inequalities, public mental health and suicide prevention. We've asked Lee to provide us with a brief public health perspective, sharing with us the wider determinants of mental health and the interface between physical health and mental health, all from that Norfolk perspective. So please welcome Lee.
Thank you very much. I've got two challenges. Firstly, to keep talking into this microphone, but also to stick to 10 minutes, so I better get going. If we could go to the next slide, please. Oh, I've got the buttons here, haven't I? Sorry, that's me bringing my inner Chris Whitty out. Agenda. These aren't my slides. Hopefully we'll get there. Here we go. So thank you again. Really appreciate the opportunity to speak to you all this evening. I'm here to really lay out some Norfolk context, describe a bit about what a public health approach to mental health could and should look like, and also talk about some of the opportunities and my kind of hopes for the future for us as well, because there's already some really exciting things going on in Norfolk and hopefully even more exciting things to come. So this looks hopefully okay for you, or you're relatively close to a screen so that you can see it. But some information on the screen there about Norfolk, and I could have picked huge amounts of data to draw from. But just under 1 million people living in Norfolk, 940,000, of which 1% have a serious mental illness diagnosed, and some modelled estimates suggesting that about 118,000 will have depression or anxiety, not necessarily a diagnosed condition, but certainly an estimate of that's what we've got in our population. And of course, all of the stigma that's attached to that means that actually people accessing help, it doesn't necessarily get to that point. The bar graph that's there just is some survey data, which is something that we rely on an awful lot in public health, and it just shows some scores that happen, it's an annual population survey that happens across the country, and Norfolk generally is somewhat, we look very similar to the England average and the East of England regional average, which is something that happens, I think it's fair to say, in a lot of our population health level data. So we're actually, in terms of life expectancy, so how long someone can expect to live who's born today in Norfolk, slightly better than the England average. But when we then look at healthy life expectancy, so how long will someone live in good health, unfortunately we're not any better than the England average. And the really important thing that I'd want to drive home, that I'm sure many of you will be aware of, is the significant inequalities, a significant variation depending on where you're born, where you live, where you grow, or perhaps particular cohorts that are at higher risk of physical and mental ill health. I also just wanted to touch a little bit on the bottom there around physical activity, one of the things that will hopefully be a bit of a theme throughout this evening, and something that I'm really passionate about because of the significant value that can have to people's physical and mental health. And again, we're not significantly different to the rest of the country in that regard. So self-reported, 68% of people report that they do 150 minutes of physical activity each week. The really important caveat with that is that when you strap some objective measure onto people, it's really very often overestimated how physically active we truly are. So it's always important to bear that in mind. And again, variation depending on your age. So certainly as you get older, and in Norfolk we've got an ageing population, physical activity tends to drop off a bit of a cliff when you get to your 70s, 80s. So again, in terms of the benefit that will have for people's physical and mental health, really important to consider. So physical well-being and mental health, deeply connected. And this is this Venn diagram that's on the screen there is a piece of work that's been done by the Faculty of Public Health, trying to pull together the empirical evidence to understand, where does that overlap sit? And it's really important to note that mental health often precedes physical illness, so mental health problems often precede physical illness, not necessarily diagnosed, but certainly there are poor mental health that then will proceed sometimes in up to 8 years in advance of physical illness being diagnosed. Mental health conditions often mean that some of the risk factors for poor physical health, smoking, diet, physical activity, etc., are less likely to, we're less likely to look after ourselves in that way. But also, as I'll come to slightly later in the presentation, the places that people are living and the conditions that people are living and growing up in are often not helpful and actually creating barriers to those healthy lifestyles that we might want people to be getting involved in. On the flip side of that, if you have a physical condition, so long-term reduced mobility, pain, fatigue, depression is up to 2 to 3 times more common in these individual cohorts. And again, that then throws up the question of which one precedes, which is not always necessarily easy to understand. Another really important point, and this is across the national picture, is that those who have a serious mental illness, so the 1% that I referred to earlier, face the greatest disparities in terms of their physical ill health. And some of those are really quite stark. One of the particular issues in this regards is that those who have serious mental illness will potentially struggle with disease treatment compliance. They therefore may be more likely to have treatment failure. There'll be increased treatment costs, much worse prognosis, and ultimately that can result in a poorer, worse life expectancy and the gap there is between 15 and 20 years in comparison to the general population. So I just want to try and describe a population health approach to public mental health. So very often we tend to focus in, and rightly so, we need to provide provision and support to those with the poorest mental well-being. So if we look at this kind of normal distribution of well-being across the population, this is fictitious data, but essentially what we're trying to do, as well as making the work that we do with those who need particular support for their poor mental well-being as equitable as possible, both in terms of access and experience and outcome. Actually, what can we do in this yellowy orange box here to shift the mean? How do we get everybody or the bulk of the population to have increased mental well-being, hopefully creating that right shift that then reduces the number of people who have poor mental health and require that support? And this requires a whole society approach. So very often you'll hear public health described as the art and science of improving and protecting people's health. But really importantly to me, it's the collective efforts of society. So it's not a particular team. It's not a particular set of professionals. How do we work collaboratively to create that right shift? This possibly isn't new to anybody. This model here has been in public health practice since 1991, and yet still we are where we are. So really this highlights that the conditions that we live and work in, those bits in the sort of rainbow there around education, the work environment, unemployment, housing, really do have a fundamental impact on our own health and well-being at an individual level, but also really importantly at a population level. So many of the inequalities that we see in society are driven by these living and working conditions. I also felt like we needed to mention the fact that we need to think about a life course approach in everything that we do. So actually this diagram doesn't take into consideration the importance of pregnancy and good health in pregnancy, but then actually how do we really try to factor in the protective factors right the way through the life course from pre-birth through to older age. And of course there'll be multiple risk factors that cut right the way across. So for example, sleep and substance misuse, really important factors that we can think about right the way across the life course. But also, are there some really important bits in that working age population, the importance of good work, not just work, but good work for people's mental health and well-being, and of course their physical health as well. So just want to now orientate slightly towards some of the opportunities that we've got in Norfolk, because I think it's we've been on a really positive journey, and I think there's lots that we are working on now and also that are coming through in the future. So at a kind of program project level, we've already talked a little bit about annual health checks and the importance of those, and a significant target going forward of 75% of those that are diagnosed with an SMI to receive that annual health check, which is looking at physical risk factors, high blood pressure, cholesterol, behaviours such as smoking, alcohol, etc. Also really important to look at the sort of emerging work around how do we work better as a system together at a local level. So, we're a big geography in Norfolk. That doesn't come without challenges, but actually how do we orientate some of our teams that have all got, consistent interests in terms of people's physical and mental health? How do we treat the person as a holistic piece rather than cutting them up into their specific disease types? And that slide has not come out very well there, apologies. The final point on there is some of the strategic levers that we've got. So there's Health Inequality Strategic Framework for Action across Norfolk and Waveney, where there are lots and lots of work going on at an individual organisation level, but also at a partnership level to try and improve health inequalities across Norfolk and Waveney. And my final point really, and again, this is hopefully a bit of a segue onto some of the future conversations, is some of the things that we've got around physical activity in the county. So many of you will be aware of Active Now. Active Norfolk's sort of single place for healthcare professionals to refer through to. Really great set of interventions and support that's available there. And just last year, the creation of the SMI pathway that really just provides an enhanced level of support to individuals to try to overcome some of those barriers to gaining access to physical activity opportunities. And if we go back to the thinking about the wider determinants and the environments that we live and work in, some of the work that our district councils are doing around creating spaces and places that enhance the opportunities for people to walk and cycle as part of their everyday transport and things like that. So, in summary, thank you. Really appreciate the opportunity to set context and look forward to the rest of the speeches today.